So, Dr. Tamburri, I'm going to let you take the reins here and explain what we're looking at. For those watching, you can look at the show notes to watch the presentation, to see the slides that we're advancing. If you're listening, you can download those in the show notes as well. But go ahead, Dr. Tamburri, and I'm going to advance to the first slide here, which is really just a deep dive into prostate cancer in the U.S.
Right. I don't want to get too hung up on the stats part. I think anyone listening understands prostate cancer. It is the most common form of cancer in men. It used to be lung cancer, but now it's prostate cancer. You can see some of the stats there: 248,000 new cases, 34,000 deaths, 1 in 6 time lifetime probability. So these are real numbers. Keep in mind, statistics in general, you have between 1 to 2 million, depending on the year, cardiovascular deaths. Half of that, roughly 600,000 deaths, are cancer in general. And half of that, just to be more timely, were COVID deaths. Now, I know there's a debate about how COVID's reported, not to get into that, but you can kind of get a sense in your brain. If 300,000 COVID, 600,000, double that is cancer, and then doubling that is cardiovascular. It's something that I've always remembered, like the whole hierarchy. But still, we have the second most common in general is cancer, but for men, it's prostate cancer by far.
So let's pause there for just a second.
Sure.
Pre-COVID, maybe a few years ago, there was a cancer society that recommended, okay, now screenings are at this age versus the older age. And now with COVID, it was, kind of our health was top of mind. And we were talking with our doctors and talking, about different things with our doctors more frequently because of COVID. And do you see in your practice and the physicians that you're working with, as well as the team at Exosome, are you guys seeing an increase in cases? It looks like we're seeing an increase in cases in 2020 alone because of because COVID has put everyone's healthcare at the top of mind, and physicians are having these conversations and asking a question like, let's get you screened.
Well, absolutely. I mean, there was a lull for a while in just patients coming in because of COVID. There was also a change, and I don't want to jump ahead too much, in what cancers were going to be treated. Strangely enough, during the lockdown, Gleason 7 cancers are jumping ahead, but Gleason is the aggressive marker after a prostate biopsy is finding cancer, a score from 6 to 10. And as we'll see with the ExoDx, it helps determine low aggressive cancers that are considered 6s. A 7, 8, 9, 10 was considered aggressive. The question is a 7. Everyone agrees that a 6 is low aggression. Everyone agrees an 8, 9, 10 is high aggression. The 7 is kind of where people argue, is it a problem or not? And before COVID, 7 was automatically considered by the standard urologist is something worthy of surgery. But during COVID, something interesting. The urologists that were told not to do unnecessary surgeries began to include low 7s. Those are 3+4 Gleason scores. They began putting low 7s as part of the 6s and pushing off the surgeries. So I found that interesting how the COVID world kind of affected prostate cancer and kind of made urologists sort of choose one way or the other, and also delay screening for many patients who they thought, they were active surveillance, very low risk of cancer.
And that moves us into the topic of men's cancer. This is an issue for men, and an important one. And so talk to us a little bit about what we're seeing here in the news about prostate cancer in the news. And
it's very timely. You're always going to hear, some new celebrity with prostate cancer. It's out there. Ben Stiller famously had it. He was on the Howard Stern show talking about it. And as we'll get to, it affects, all backgrounds. It does affect Black men and white men if they're German or Scandinavian background much more. I ask all of my men what their heritage is, and you'd be astounded. I was surprised, I found this out just doing this job long enough. I would say 80% of my men are all German or Scandinavian background.
Wow.
So if you have that, certainly, it's flagged. And I'll joke around. I'll say, if you're a black man named Hans or Franz from Germany, I charge you double. It's like massive risk. Next slide here, we have the diagnosis around 17%. If you do have it, 3% ultimately to be fatal. I know urologists have told me through the years, and depends who you talk to, it depends on the study, and it depends on the year. That's when it comes to prostate cancer, there's no absolute. The American Urological Association will say one thing, and the Journal of Medicine says something different, but you get a gist. In essence, when you're diagnosed with prostate cancer, there is between a 1 out of 20 or 1 out of 40 chance of dying. And again, based off different studies, I kind of split the difference. And when I'm doing the quick version, I say about a 1 out of 30 chance. But for a lot of men, that's good news right out of the gate. They hear the C word, they think they're dying next year. They have no idea that the odds are in their favor. The question is, are they the 1 out of 30? And that's really what I focus on, and how the ExoDx helps men figure that out too, and for the physician. This next slide, thank you. Talking about PSA in general, it's been used since 1986, especially. The PSA was put into place because the only marker we had back in the day was called the PAP, the prostatic acid phosphatase. You'll see that again in a few moments when we get to screening tools. I'll go through that quick, but eventually people wanted a test that didn't tell you after prostate cancer spread throughout the body. They wanted to know before it spread. So what's the chance you have it ahead of time? It came out in the 1980s. It took about 10 years for doctors to start to realize that there were many false positives to the PSA. And that led basically to people like me having a job, but it took many years for doctors to start to question this. Like anything, it takes a number of years for the early adopter doctors or the anti-establishment doctors to question it, and then eventually it becomes mainstream. In around 2006, 2008 is when most physician groups began to recognize that the PSA had some major problems. Then you started having the flip side, where then groups were saying we shouldn't test PSA at all. And that was the other problem. We're going to start getting into let's go back to the main slides, the ones I mentioned earlier at the top there. But the problem with the PSA is that, like everything in America, it seems, we have two extremes, right? We have a group that will say the PSA, if it's over 4.0, which is the cutoff for the standard system, then automatic biopsy and it's a problem. Then you have people on the other side who throw the whole PSA out and say, oh, don't trust the PSA. I think the reality is that the PSA is a good test. It just depends if you know how to read it and interpret it. It's like anything, it's a tool and how you use it. So the PSA is a test that it has utility if you know how to use it. And I'm going to give you some thoughts for some of you doctors about how to learn about PSA, some things to read about if you want to utilize PSA better. But whether you do that or you don't have the time to focus in PSA to that degree, as we'll get to, molecular tests like the ExoDx are ways to kind of shortcut that, or at least give you a powerful perspective whether you understand PSA kinetics or not, but we'll get into that.
So
now,
let's pause I want to pause for a second.
Yeah,
so I don't want to, for those, maybe listening to this in the car on the way into the practice or late at night while they're charting, we're not jumping to the very end, but what is the Exosome DX test? And why should these physicians be leaning in to the rest of the series?
Well, as I'll show in a second, I utilize three major factors when I assess prostate cancer. So my practice is mainly made up of men who either have an elevated PSA and they want to know, do I have prostate cancer, where a risk high enough that I need a biopsy? Or the other half of my men have already been diagnosed with prostate cancer and they're trying to figure out, do I have the cancer with a capital C or the lowercase c? In other words, should I really get this removed or not? Because patients are being told all sorts of pieces of advice. So I'm trying to assess whether they have a problem or not, or put in Dr. Tamburri terms, do you have a poodle or a pit bull lying there? Mm. And we're going to talk about some ways to help refine that. But the ExoDx is it's a molecular test that has nothing to do with a patient interview. It has nothing to do with even their PSA. As faulty as the PSA is, this test or type of testing, molecular tests, are able to determine a high chance, a high degree of efficacy here. In this case, 90, so like 91, 92% for the ExoDx, the chance that an aggressive prostate cancer is present. Now, that's a very loaded statement on many ways, like what does aggressive mean and all of this. But in essence, it helps you right out of the gate without having, we're not even talking to your patient really. And I don't advise that, of course. But again, what is the chance? Is there higher than, in this case, 91% chance? But, just being fair, is there, on a flip of a coin, is there more of a chance that this patient has a pit bull cancer that they need to take seriously? Or is it probably what we would often call an indolent cancer, or in layman terms, the old man cancer variant, where chances are they're going to die with the cancer, and maybe they're a good candidate for natural treatments. So in many ways, it's kind of a litmus test here that I use. I don't use it by itself. I use it as part of two other categories that we'll get to in a moment. But yeah, no, thanks for bringing that up. I want to get to the big picture of what is it, what is ExoDx, and how to utilize it. So it's a very powerful test and type of test. And by the way, one other thing about the ExoDx that we'll get to is it's the newest addition to a family of molecular tests that I've been running for 15 years now. Or the original we'll get to is called the PCA3. And these tests, you had to see a urologist typically, and they had to perform a very vigorous, my guy's not always liking it, DRE before you collected the urine for the test. The ExoDx, what makes this much more, I think, useful, especially in the post-COVID or during COVID world, is that this test, you don't need to conduct a DRE. So you do not have to do a prostate exam. And for people who have patients out of state and out of the country, like I do, this is something you can send to the patient. They collect the urine at home, and you don't even need a DRE. So this opens up the gate to many other doctors that probably maybe don't focus in prostate cancer, or doctors that really don't like to do DREs, don't have the experience for it, but they want to have an idea before they scare their patient and refer them off to the urologist, which is like going down a whole nother rabbit hole sometimes, that this test could be a great deciding factor to help them before they make that referral. So going back, if you could back up to that prior slide for me for a second, here's what I'm going to recommend for people who are even dealing with prostate cancer risk. These are the three top questions that are paramount when you speak with a patient. If this is probably worth the price of admission alone to this whole lecture, in my opinion. It took years for me to get to these three basic questions. It's going to sound a bit simplistic. But when I have a new patient in front of me and I ask them, why are they here? And they say, well, what do you mean? I heard you're the prostate guy. Do I got prostrate cancer? And first off, if they put an R in there, prostrate, I charge double. Okay, that's just a rule of thumb that I have. Even my father even still says that, and I do this for a living. But anyway, the first question.
I was given a podcast a couple hours ago, and I said regret. So, and I meant to say regret. So like my father-in-law says, son, you're allowed to make one mistake a week. So
you are. I trust me, I'll make a few. But that's one that's always comical in our office. But what are the three questions? Number one, is the question, do I have a prostate cancer? Or is the question, am I going to die from it? Those are two completely, profoundly separate questions, especially when most patients come here and they say, I've heard that cancer doesn't kill you, right? Which is not always true. Most prostate cancer does not. So, all right, well, then if you just want to know if you have cancer, go get a biopsy. But then they say, yeah, but I thought we all have cancer in us all of the time. And it's true. So if we have cancer all of the time in us, then why are you asking, do I have prostate cancer? I could assume maybe you do. You biopsy me enough times, you're going to find it. Maybe the question is, am I going to die from it? And that usually starts to change the conversation. The second question, which sounds similar but equally powerful, is, do you just want to know if you have prostate cancer, or do you want to know why your PSA is elevated? Because most men who are being flagged to come to me, those that have not had a cancer diagnosis already at least, the only reason they're there is some doctor got wigged out, which is a medical term, because this thing called the PSA is elevated. And many of these men don't even understand what this test is. So is the question really, is cancer, or why is the PSA high? And as we'll see in the next slide in just a moment, that's really where I focus on, and how the ExoDx helps refine the chance that a PSA is coming from a more aggressive cancer or a cancer at all. And the third question, the most important, ultimately, most of my patients haven't thought this through yet by the first visit. It takes a few visits. But is the priority in their treatment longevity of life or quality of life? And that's the question the conventional system doesn't care about. To them, it's all longevity. Keep in mind, all the actuarials and their numbers, everything's based upon keeping human beings alive the longest. So, if they put your head in a vat, of ice, like Walt Disney, apparently, legally, technically, you're alive, but quality of life is not quite there. That's sort of where the system is. That's why they will rip out your prostate and not ask you, are you still having sex, or how important is it to not be incontinent in your lifestyle, or did you just get remarried recently to the love of your life and you don't want to lose have erectile dysfunction, or lack of orgasm, or what have you. They don't ask these questions. It's just as long as you're alive long enough, they just feel they can't be sued based off of that metric. So it depends on the patient. Do you want to see the grandkids get married, or do you want to have erections to your 200? And I do phrase it that way. And my patients, they really appreciate that question because no one asks them that. So those three, if you remember nothing else, remember those three, and then everything else just fits in as you go through the consultation. All right, so this next slide it's pretty much the only thing in my brain. I have these three circles. That's my whole practice, are those three circles. So once I get past, the question, do I have cancer? It becomes, why is the PSA high? And therefore, this is what you're dealing with. There are three main reasons the PSA can be elevated. Number one, when a PSA is under 10, okay, so the PSA is 2,000, that's prostate cancer. But the PSA, if it's between 2 and 10, statistically, the number one reason it'll be elevated is prostatitis, which, by the way, does not mean infection. It means inflammation of the prostate. Only 10% of prostatitis turns out to be infectious. So you're looking at many other things that can cause prostatitis, of having too much sex, not having enough sex, believe it or not, irregular sex, rectal intercourse. I ask my patients all of these questions. Like I say, political correctness by not asking kills patients. So you ask this, riding motorcycles, quads, speedboats, things that bump and bang, motorcycles, if I didn't say that, horses, bull riding. I got a lot of cowboys out here in Arizona. Having an autoimmune disease. If your body's inflamed, your prostate's part of your body, that could be inflamed. Having COVID, getting the COVID vaccine. Or what I mean by that is, I have many patients that got their PSA pulled the same time they got vaxxed. Well, that's, that's not good for possible localized or temporary inflammation. It can throw it off. Getting the flu, being hospitalized, having massive stress. I could keep going. There are being an airline pilot, flying in an unpressurized airplane where the prostate can expand. There are many reasons why all of those can create a form of prostatitis, either direct to the prostate or systemic in the body that affects the prostate. The second most common cause of the PSA going up is BPH, which is a benign prostatic hyperplasia, not hypertrophy to be technical. So that means there's more cells. If there's more cells in the prostate, and each cell makes PSA normally, you're going to have an increase in PSA. So there we go. The PSA increases again. And many men have both BPH and prostatitis to some degree. And then lastly, the least common, if you're just going to play the odds in Las Vegas, is prostate cancer. That's the least likely, statistically, of a PSA from 2 to 10. Of course, it's the number one reason you'll get sued if you miss it. And that's why the conventional system jumps to prostate cancer as the number one rule out. The quandary that you have is that, and now put this together, guys, and some of you, if you happen to be a urologist, you might be doing this and not know it. Think about this. If the number one reason the PSA is elevated around that range, which is where the people that I'm normally seeing, is an inflamed prostate, and you don't spend more than 5 minutes with your patient to ask difficult questions or tracking over many months to see why the PSA is elevated. In other words, if it's inflammation that is causing that PSA to be increased, which statistically is probably what's going on, but you are afraid of being sued and you jump to prostate cancer, rule out, how do they rule it out? A biopsy. And a biopsy is taking 12 needles, shoving it through your rectum full of E. coli and peppering the prostate with it. So if you were worrying about what can inflame a prostate, a biopsy will do that. And the irony is that the biopsy itself they'll cause prostatitis and hence the PSA increase. If they don't find cancer, hopefully if cancer's not the problem, then you're good. But if they do find cancer, which is common, just as I said, you biopsy me enough times, you might find something. God forbid they find a little bit of a cancer, an indolent cancer, low aggressive cancer even. The system will look at a PSA that's elevated and then finding cancer, and they equate the two. And then if the PSA goes up after the biopsy, often they use the increase in PSA as further reinforcement that you have a cancer problem that's worsening. You understand? That is the loop. And many doctors do this. They don't even understand that's happening. So I try to acknowledge all of this, account for all the PSA issues. And as we'll get to again soon, the ExoDx or molecular tests are a way to determine the risk that a cancer is there or an aggressive cancer being there, more precisely, whether the PSA is reliable or not. But I wanted to explain that. Next, how you break this down. So when I do an assessment for patients, I look at three main components. First is the general history. We have down listed here family history, but it also includes PSA Kinetics, basically all the labs. So family history, the PSA Kinetics we're going to address in the next slide. Urine analysis, very important. The American Urological Association score. For any of you who's dealing with urology, please look that up. It's a standardized form, the AUA symptom score. I give that to every man walking in. It's more important than taking their blood pressure in my office. 7 quick questions. Do they have urgency, frequency, how many times they pee at night? And you can track it each time they come in, whether they're getting better or not. The bottom line with the AUA is, if they have symptoms, Dr. Tamburri is happy for them. Why? Because prostate cancer doesn't normally give you symptoms. Prostate cancer is insidious. So the more problems you have, the more likely prostatitis and BPH is present. So right there, symptoms are really a powerful tool. We take a history, family history. We touched on that a little bit earlier. Environmental exposures. A lot of my men from Vietnam, they had Agent Orange. They played in mosquito truck fogging, but when they were kids, DDT, 2,4-D. I have international patients. I've had 3 of them that came from Poland, each younger than me, and they each were downwind from Chernobyl when they escaped the Soviet Union. And all 3 of them had Gleason 9, 10, very aggressive cancers. So I always ask prominent, long backgrounds. And then prostate activities, mainly to rule out prostatitis, and I talked about them earlier. The second leg, so all of that is just one leg of the stool. What's the other leg of the stool? The physical component. So that's doing the infamous DRE, the digital rectal exam. That also is a biopsy. If the patient has had a biopsy, it is good information. I don't throw that information out. Biopsies are great info. The problem with the biopsy is that even if the biopsy is positive for cancer, it doesn't necessarily mean they're going to die from it, which is what a positive biopsy usually means to a patient. And if you have a biopsy and it's negative, it doesn't mean the cancer is not there. They may have missed it. So you have to take a biopsy with a grain of salt and know how to interpret it, but it is powerful information. Also, imaging, which is now becoming more popular. I've conducted imaging. A handful of urologists have been doing imaging for about 20-something years, but that was very obscure and people at the time thought it was worthless. Now it's becoming the bee's knees with MRIs now that reimbursement is paying for it. But there's MRI, transrectal ultrasound, and then, of course, color Doppler to really soup up the ultrasound, which basically means that when the heart beats, you can see the blood flow through and feed the cancer or feed areas of the prostate. So all of that. So we have two legs of a stool with all of that information. The reason I went into that is, what's the third leg? All by itself, sitting on a hill, the way that I practice, are the especially biomarker tests. And the ExoDx is the newest version of them. The original was called the PSA3. I think I was the only naturopath that ran that one back, 15 years ago, whatever it's been, 18, before it was FDA approved. It came from overseas and from Scandinavia. The PSA3 eventually became another test called the Michigan lab test. At least that's how I've seen this evolve. That eventually became a test called the Select MDX, and that has now kind of like new updates on your phone. And the newest, and personally, I find the most useful at this point is the ExoDx, which is one of the reasons I agreed to speak for Exosome, is because I do use it as my primary biomarker test. But I wanted to explain how it's used almost as a referee between those other two legs of the stool, and how powerful I find that it is. All right, lastly, before we start getting into the ExoDx more details, PSA. I just want to tell you guys, PSA, it's easy to poke fun at it and throw it out, and you can. If you go to, I tell my students or my patients, if you're going to your church where you have a screening van coming to do medical tests for you for free, I mean, it's nice they're doing it, but I would run for the hills if they're going to do a PSA on you, because they don't understand how to interpret the number. The standard PSA is, according to the government and the insurance, is 0 to 4 is normal, 4 and higher is abnormal, get a biopsy. That's how they read it. That's how most of you may have interpreted the PSA, because on the lab sheet, 4.0 is the cutoff. However, more medically progressive urologists, including myself with this, we're seeing, we use more of a green, yellow, red approach, more of an analog approach of gradation. So instead of black or white, under 4 is good, over 4 is bad, green is good, red is bad, high risk for cancer, but in between is the yellow zone, where it just means we need more information, something's flagged, let's try to get more info. So therefore, 0 to 2 PSA is considered now the new green zone. 10 and over is the red zone. So when I have a urologist that wants to do a biopsy on a 12 PSA, whether I agree it should be done for that patient or not, I'm not going to call out that doctor for overreacting. I understand when it's over 10, even they're caught in a box. But 2 to 10 is where many of us, maybe concierge doctors, we see many patients, and that's a perfect patient for this type of analysis, and especially the ExoDx. When we go back to the other slide for a second, I'm not going to go in detail at all of these, but I want to rattle off what you can do with the PSA. There's a PSA pattern. Does the PSA spike? Does it go up like a staircase over time, like cancer? Does it bounce up and down like the stock market? That's more like prostatitis. Or does it have a slow increase like a growing prostate? PSA velocity is the rate of change. How quickly does it grow? Does it increase per year? The percent-free PSA, I highly recommend you guys run that on each of your patients, because it can tell you the chance that the PSA nominal is coming from cancer versus BPH. The PSA density, which is taking the PSA and dividing it by the volume of the prostate. The larger your prostate, the higher your PSA is allowed to be. Makes sense. And then we talked about symptoms, a urinalysis, and the PAP, which is an oldie but goodie to help determine the chance that a prostate cancer has already escaped the prostate. So all of that is like an hour lecture in itself, but I just wanted to throw out that the PSA has value if you use all these different ways of interpreting them, which we call PSA Kinetics. But whether you do kinetics or not, you can still utilize the ExoDx very easily.
Well, I hope you've enjoyed part 2 of our interview with Dr. Phranq Tamburri. This is really amazing stuff, and I want you to go check out the links in the show notes below. Go dig into the research here, dig into the medical evidence that Dr. Tamburri has shared. Part 3 is going to be coming up very soon. You can click on that in the link below or maybe above, and we'll see you right here next time. Go check out part 3 with Dr. Phranq Tamburri. I really think you're going to enjoy what you're hearing, and hopefully this will change And this is a tool that you can use inside of your practice. So go check it out. Go ask the team over there at Exosome. Check it out in the links below. I'll see you next time.